Okay, everyone, just being respectful of everyone's time here. We'll probably jump into the session now, and just mindful that it's a Wednesday morning, so people may be busy with, work and other things. So hopefully people will jump on board as we proceed. So thank you, everyone who's joined the session so far. Thank you for coming along with us on this really valuable session and what we hope will be really useful for everyone that's attending today. So welcome to DPV Health. This is the Women's Health webinar, the first of 3 sessions that we will be running over the coming weeks. My name is Pooja. I am the Marketing and Client Experience Manager at DPV Health. I will be moderating the session today, and I will hand over to the team presenting as we go along. I will start by acknowledging by the acknowledgement of country. So DPV Health acknowledges the traditional custodians of the lands and waters on which our services and sites are located. We pay our respects to elders past and present and extend our deepest regards to all Aboriginal and Torres Strait Islander peoples, including any who may be with us today. So before we get into the session itself, I'd like to share a few housekeeping rules with everyone. This webinar session will be recorded. The recording will be shared with all the participants via a link after the webinar. And it will also be shared, may also be shared online via the DPV Health website and our social media platforms. Can I request everyone to please keep their microphones muted for the entire duration of the webinar so that there is minimum disturbance or disruption. Participants can submit questions at any time during the session using the chat feature. You will find it on the banner, the tab banner at the top of your screen. It says chat, so you can just submit your questions at any point within that feature. Please demonstrate mutual respect for all the presenters and all the participants online and avoid any kind of negative comments or criticism during the session, please. Okay, I will now hand over to our Women's Health team, the champions of this particular webinar series. They will take you through some really useful and what we're hoping are invaluable slides. So I'll hand over now to Gulchan from our Women's Health Nurses team. Thank you, Gulchan.
Thank you, Pooja. Hi, everyone. First of all, I would like to introduce myself. My name is Gulchan and I'm the nurse lead here at DPV Health. It's a pleasure to welcome you all to the very first session in our Women's Health Matters webinar series. Whether you're here as a professional, health professionals, community members, or a simple someone eager to learn, we're so glad to have you with us. Sorry, I'm a little bit nervous. It's my first webinar. The sessions are all about empowering informed choices, breaking down stigma and making sure everyone has access to the knowledge, support that they deserve. So let's keep the conversation open and make this a safe space of learning and sharing. So a little bit about DPV Health. DPV Health is a primary care provider operating in northwest of Melbourne, offering a range of services including allied health, dental, counselling and medical services. Next slide, Pooja. And the first sorry, I was going to talk about our DPV Health. So DPV Health was, sorry, my computer's closing. Sorry, about our services that is operated through our medical clinics in sexual health and reproductive health hubs. We offer a range of services for women, Some of them are led by nurses and other GPs. Some of them are nurse-led clinics, including sexual health assessments. We do vaccinations, cervical screenings, and implant on insertions and removals. That's all led by nurse lead. In addition to the nurse-led services, the GPs provide services including STI screenings, treatments, pregnancy, and fertility support and guidance, and contraception options, including the things that we are speaking about later today, which can be booked online through our website. Next slide. DPV Health Sexual and Reproductive Health Hub operates from our 2 medical clinics, which is one of them at Broadmeadows and the other one's at Mill Park. So both clinics are very close to the train stations, so they have easy accessible and by public transport, and we also have car park available on site. We now have move on to the sexual health team. So we've got which includes amazing GPs. So we've got Dr. Jallam at Mill Park. We've got Dr. Christina Port at Broadmeadows. And we also have a team of 5 registrars that work from our Broadmeadows location, have a special interest in women's health. So that's and then we have our nurses, which they're all trained. So we also have a team or nursing team of 8 nurses. We all completed comprehensive sexual and reproductive health training. Across the team, the GPs and nurses speak 9 different languages. We also have access interpreter service that patients as need ensure that everyone has the same access to the service. So appointments with the doctors and can be booked in on the phone or through our website. So another really important part of our team is our wonderful doctor, wonderful gynecologist, Dr. Vaishali, who is our guest speaker for the day. And I will hand over to Dr. Vaishali now for her parts of the presentation.
Thank you, Gulchin. I have to apologize to all of you in beginning because I'm having a little bit of sore throat since this morning. So I might be coughing in between and might be sipping some water. So I have been deeply passionate about women's health for over 3 decades. And the excitement I feel when speaking about it has not faded one bit. In fact, after 33 years, it's only grown stronger. So I'm truly thrilled to be here today sharing that passion, knowledge, and experience with all of you. A heartfelt thank you to Laura, Pooja, Gulchin, Brianna, and all of you who have made this moment possible. Just 75 years ago, women did not have the autonomy to choose when or if they wanted to become pregnant. That fundamental freedom began with the invention of oral contraceptives, a breakthrough that empowered women to take control of their reproductive lives. Pregnancy transforms every aspect of a woman's body and life. So the decision of when to embark on that journey must rest with her and her alone. And I'm sure all of you will agree with that. Since the advent of the pill, we have made incredible strides in the women's health, but the journey is just begun. There is still progress to be made, and I am honored to be part of that ongoing stories. I have a disclaimer that this presentation is made by Gulchin and Brianna, and Pooja has made it more beautiful, and I agree with this presentation. So what is family planning? So all over the world, in most of the countries, family planning means only contraceptive choices. But I feel this definition, what is given here, is more right. Family planning is the broad term given to the practices that allow individuals to make informed choices about their reproductive lives. And that includes fertility choices, like when do you want to get pregnant, and if you need, then the treatment of infertility, and contraceptive choices. So this avoids unintended pregnancy and allows decision making regarding if and when to have children and how many. Family planning is important because it reduces unintentional pregnancies and related health risk and supports gender equality and women empowerment, as I mentioned, and it enables the access to education and economic opportunity. Next slide, please, Pooja. So methods of contraception, what is most commonly used over the years before 75 years, and still there is a cohort of couples which use it, which is not mentioned here, is a withdrawal method and safe period method. These two methods, I'm sure that most of you guys know those things. And if you want to go in detail, I'm happy to talk about it. And barrier method condoms, they have got higher failure rate. Almost 20 out of 100 couple using those methods can get pregnant. The other methods which are more sound and less causes less incidence of pregnancy are hormonal methods, intrauterine devices, permanent methods, emergency contraception. And I'll be going in details with that. But before I do that, I just wanted to have one poll I wanted to take, and you can just click on the raise hand, and then we can say take the same poll at the end of the talk. So I just wanted to ask you guys, I don't know how many professionals are there, but yeah, you can choose to raise your hand if you want to. So have you ever felt confused about different types of contraception available? The answer is yes, or still unsure. Those people who have that, they can click on the raise hand on the top portion of the screen. And we can take the same poll at the end of the webinar. So moving forward, the barrier methods. The barrier methods of contraception are widely available and offer a non-hormonal way to prevent pregnancy and protect against sexually transmissible disease. So in Australia, Australia is a little bit different than rest of the world. Here, the women and couples are using more of oral contraceptive pills and condoms, whereas the rest of the world use more of long-term contraceptives in terms of IUD or depot or injection and permanent method of contraceptions. So we are different than rest of the world. So what are the ways the barrier method can be used is external condoms, which is well known for last almost 300 years. The humankinds are using that method, and as you know, it's worn on the penis to prevent the sperm from entering the vagina. This is totally male dependent. The internal condoms are vaginal condoms, which is worn inside the vagina. So it's depending on the women. Diaphragms, it is a dome-shaped cup, which is worn a couple of hours before the sexual act and should be removed almost 8 hours after the sexual act. And same with the cervical cap, which is worn on the cervix. The diaphragm and the caps are also in market for almost 150 years. From 150 years, it needs a little bit of training and can cause a little bit of discomfort. So all these methods, as I was saying, that they were 20% failure rate. Two drawbacks of this is that they are act related. So younger populations struggle to use that. Second thing is that there can be accident because of the tearing of the condoms or slipping of the diaphragm or cervical caps. And that can cause increase in the failure of the contraception. But important thing about the external condoms is that they prevent the STI. That's really good. but we can't say the same thing about the internal condoms and diaphragm or cervical cap, because semen still comes in contact with the vagina with last three methods of barrier methods. So we can talk about it more if you want to know more about that. So next, yeah, good. The hormonal method. During the contraceptive assessment appointment, your doctor will work with you to determine which method suits to your body, lifestyle, and health needs the best. And the contraindication will be ruled out, whether you can take those hormonal contraceptives or not. There are some contraindication, and of course, with everything which humankind has made, there are good things and bad things. So hormonal contraception are not the exception. There are side effects, there are contraindication, there can be complication. So it's very important to see a health care professional before you go on the pills. And that's why in Australia, they are prescribed, not like some countries where you can just obtain them over the counter. So the types of hormonal methods are oral contraceptive pills. These can be combined pills which have got both the hormones, estrogen and progesterone, or it can be a progesterone only pill, and they are taken orally. The second is injectable contraception, which are depot contraception, which is only progesterone hormone, and it is usually given 12 weeks. In some condition like epilepsy, it should be given every 10 weeks. Vaginal ring, which is called as NUA ring, usually it has got progesterone, but some country just has ring which doesn't have any hormone, and it is inserted into vagina for 3 weeks and removed for 1 week so that a woman can get a period. Hormonal IUD, Mirena and Kylina, is the small T-shaped devices which are inserted into the uterus, are done with trained professional, either by nurses or GPs or a gynecologist. And Kylina lasts for 3 years, and Mirena can last up to 10 years, depending on what age you fall in. And the hormonal implant, which is an implanon, which is a small rod, again has progesterone, which goes under skin of the upper arm, and which requires a replacement and a small procedure to put in and taken out every 3 years. Next slide, please. So what are the benefits of hormonal methods? In addition to preventing pregnancy, they can offer the health, a different range of health and lifestyle benefits that many people find life-changing, including that it, especially Mirena and Kylina or Depot, they can make the period disappear, which can be really good for both the ends of the reproductive age, especially because you don't want to be bothered by that. In the reproductive age, in between 20 to, I would say, 40, they want to know whether the periods are happening or not because they're worried about a pregnancy. The other thing which are useful, which the hormonal pills are useful, or pills or contraceptive methods are useful for acne, for polycystic ovarian syndrome, the condition which is rising in community now, and endometriosis. It also reduces to some degrees ovarian cancer, endometrial cancer, and colorectal cancer, provided it is used up to 5 years. 3 to 5 years, there is a lot of evidence and proof that if anybody who use oral contraceptive pills, they will have some protection for ovarian cancer, endometrial cancer, and colorectal cancer. And of course, it helps some of the people who are suffering from premenstrual syndrome or premenstrual depression, migraine, can get benefited by hormonal method. Some people can get worse. So this method should be chosen after consulting the doctors. And also, to some extent, it can prevent some types of ovarian cysts, like simple cyst. We can give the course of oral contraceptive pills so that the ovarian function is suppressed and the cyst size can go down. What is the intrauterine devices? So they are the small T-shape, or some of them are curved. They are inserted into the uterus to prevent pregnancy, and it's a form of long-acting reversible contraception, and it is effective more than 99%. And it does have complications and consequences, but it's definitely much better choice than rest of the contraception if a woman doesn't want to get pregnant for a long time. Like once they have one child, it's not a bad choice. Or if a woman doesn't want to get pregnant until the age of 30, it's a good choice. So these are two types of IUDs, hormonal IUDs, as I mentioned before, Marina and Kylina. It does have the hormone which is called as levonorgestrel. It's a type of progesterone, which to some extent it prevent ovulation. And the main thing is that it thins the inner lining of the uterus and prevents the implantation of fertilized egg, and also thickens the cervical mucus and thereby prevent penetration of that cervical mucus by the sperm. So sperms can't go enter the uterus, and that's the way they prevent pregnancy. And a copper IUD, it's non-hormonal, which is widely used outside Australia and to some extent in Australia now, not available everywhere. If a woman wants to have them inserted, then they need to put in a scripts, and pharmacy will organize them to get, and then it can be used. They can also last for in between 3 to 10 years, depending on which one is chosen. They are toxic to the sperm, and they cause mild inflammation in inner lining of the uterus, and then thereby prevent the implantation of the fertilized egg. The permanent methods of contraception is another method which is more common outside Australia, but it's getting more favorite now in some of the couples here, especially the younger population who are opting not to get pregnant forever. The younger population, especially in between 30 to 35 years now. And there are two ways. It's a tubal ligation or total removal of the tube, which is called as tubectomy. And it can be done via laparoscopy or a small incision on your tummy. And it is more than 99% effective. The failure rate is around 1 to 3 in 10,000. It does not affect your menstrual cycle or hormonal level or sexual enjoyment. If a tube is totally removed, but that actually can help you preventing ovarian cancer, there is upcoming evidence with that. So women who are undergoing this via gynecologists, I usually now try to encourage them to take out the total tube because it's not just contraceptive way, but it's also give some protection for developing ovarian cancer. The only downfall is that it's a day's procedure. The woman needs to have general anesthesia or spinal anesthesia. It requires referral, and it's a operation, so has all that saga post-operative. But the other method, which is better actually, but it's male dependent, that is called as vasectomy, in which the sperm carrying tubes are a little bit of part of it is cut, and it's very quick. Some expert surgeon takes even 15 minutes or commonly less than 30 minutes, and it can be done under local anesthesia. And even in some of the clinics do that if they have operative facilities, and it's more than 99% effective. And the good thing about it that if a couple wants to get pregnant, we can try to join back the cut tubes of the sperm carrying portion tubes, and the couple can get pregnant, whereas that is very, very rare with the tubal ligation. The recovery is very quick. There are very less side effect, and it can be done by some of the GPs which are qualified and undergone training. Referrals is not always necessary. So do talk to your GP if you want to go through that. Next slide, please. This is the contraception which is commonly used by a lot of girls because it is available over the counter, but it needs to be taken with care, of course. I'll be talking about what happens, but I'll just let you know what it is first. So there are two types of emergency contraceptive pills, and it can be taken, three types, not two. So two of them can be taken by women by themselves. It doesn't need a prescription. So these are the contraceptive which are used if women had a sex with and without using contraception and they don't want to get pregnant, or if there is a condom failure or tearing of the condom or some accidents, or even in some rare forms of rape and all those things where woman has undergone the coitus or sex and doesn't want to fall pregnant. So emergency contraceptive pills are two types, levonorgestrel pills. There are different names for that, and the best effect is taken if it is taken within 72 hours or 3 days, but it can still work up to 4 days. um, about 70% of them can be successful. It is available over the counter, as I said, no prescription is needed, and it prevents up to 85% if it's taken before 3 days, and about 70% effective if it is taken before 4 days. And other thing is UPA pill. The name is called as Elaman. The timing, it is effective up to 5 days after unprotected sex. It is also available over the counter, and it is slightly more effective than the mini pill. The downfall of this is that a couple of things. First of all, this can be taken only once, for once in a month. Like if a woman had unprotected sex one time, then the pills can be effective. If it is a multiple time unprotected cells, the pills can't be protective. Second thing is that the oral emergency contraceptive method will put women at the risk of developing ectopic pregnancies. Ectopic pregnancies are the pregnancies in which the pregnancies happen in the tube instead of the uterus. So anybody who has taken those pills and they have not had their period, it's very, very important for them to check if they are pregnant and see the doctor if they're not getting the period. The third method is insertion of the copper IUD inside the uterus after the unprotected sex. It can be inserted up to 5 days, and this method is the most effective compared to the emergency contraceptive pills. It is more than 99% effective, and it will then give continued protection from the pregnancy, depending on which one you choose, from 3 to 10 years. It needs to be done by doctors or the nurses only, though. And of course, we can't be not talking about termination, because some of the cohort of our population, especially the new immigrants, they do use this method of contraception, which is a little bit harmful to women's body. So the abortions are legal in all the states and territory, depending on what weeks of termination is there. The law is a little bit different from different states. So there are two types of terminations or abortions, which is one is medical and another is surgical. Medical termination, the two types of medication should be taken. First, the mifepristone is taken, and then followed by 4 tablets of misoprostol, usually taken after 36 to 48 hours of mifepristone. Mifepristone to discontinue the pregnancy and misoprostol to expel the pregnancy. Both the tablets are very, very important. After mifepristone, some of the women have some kind of bleeding. That does not mean that they have already aborted. They have to take misoprostol. Only taking mifepristone will make the pregnancy abnormal, and it will continue if a woman has not taken the misoprostol. So it's very important to take both the tablets. Usually should be done before 9 weeks. It is effective only till 9 weeks. And these tablets can be taken at home, and it's very important to follow the guidelines strictly, because 1 in 1,000 women can bleed a lot, up to 2 liters in first half an hour. So counseling is very, very important. And 1 in 1,000 is not a big number, but that 1 in 1,000 should not suffer. And there are some rules and supports available for those who are undergoing the medical termination. So the women and the couple should really follow whatever is being told to them. If they do that, then usually they are quite safe. These methods are available all through the DPV Health and SRH hubs. The surgical termination can be done up to 20 or 24 weeks, depending on which state are you in. And I think the first trimester, the first 12 weeks, up to 10 to 12 weeks, can be done by GP obstetrician. The later on usually needs to go and get admitted in the hospital, and usually done with the maternity units. So for surgical termination, you need a referral and you need to see a gynecologist, or some of the GPs can do that. The last thing which we have to talk is sexually transmitted diseases, because the numbers are rising in Australia, unfortunately, and condoms or barrier contraception like condoms can prevent that, and we have to talk about it. And basically these are the infections which are primarily spread through sexual contact, whether it is a vaginal, anal, or oral. They're caused by the bacteria, viruses, or parasite, and some of them can be transmitted through birth, childbirth, and breastfeeding. So common type of STI are chlamydia, gonorrhea, which are the most common in Australia. Syphilis numbers are rising. It's a national emergency actually for syphilis now in Australia, because the numbers are really rising. The others are, they are very small. But trichomoniasis and genital herpes and oral herpes is also actually is increasing in size. The genital herpes are caused by HSV2, and we are seeing the increasing incidence of oral herpes by HSV2. So anybody who's having a new symptoms or getting worsening of the HSV, you should contact a doctor, and they can take a swab and find out whether a woman is suffering from HSV2 or 1. Why it is important? Because reproductive age, the women who are wanting to get pregnant, it's very important for the professionals to know whether it is SSV2, because the HSV2 in a woman's body have some implication on pregnancy and in the birth as well. Of course, we can't not talk about HPV, human papilloma virus. It's not actually declared as a sexually transmitted disease yet. We don't know exactly why. Of course, microbiologists will go in details telling why, but gynecologists, believe me, I do want it to be qualified as HPV, and a lot of my colleagues want to do that, because there is no incidence of HPV occurring into the women who are never been sexually active. And the last not the least is HIV, which is one of the very important sexually transmitted disease. So the key fact, over 1 million curable STI are acquired every day globally. And same, like not 1 million, that's a high number in Australia, but numbers are going up in Australia as well. Many of the STI are asymptomatic, meaning people may not even know they are infected, especially chlamydia infection. It can sit into women's vagina for almost 18 months and women will not have any symptoms. And there are some implications, especially with women. Untreated STI can lead to infertility or pregnancy. Almost 2 attacks of chlamydia can increase the chances of women not to get pregnant up to 25%. That means 1 out of 4 women who have had chlamydia twice in their lifetime will not get pregnant. And of course, there are complications of STI, and with infection like HPV, women are more prone to have cervical cancers, and HIV as well causes a lot of different cancers. And all the STI, apart from HIV, increase the incidence of HIV. So using condoms and regular testing are the best way to prevent and detect STI early. And if a woman is sexually active, getting tested regularly is a very good idea if they are in unstable relationship. All right, that concludes my presentation, and I'm happy to take some questions. Do we have any questions?
Yeah, hello. That was a great presentation. Thank you so much. My name's Lucy. I just wondered why women under 30 are not recommended for the IUD.
Oh, who has recommended this?
Oh, sorry. I thought I heard you say that the IUD is not recommended for women under 30. Did you say that? Or maybe I heard that wrong. I'm
not
sorry.
30. So the only method of contraception which we don't recommend for extremes of age is depot contraception, the injection. Below 20 and after 40. I'll talk about IUD in a minute, but for depot, what happens with the depot injection? We give a high dose of progesterone, and that there is evidence that they can they cause the bones. I'm trying to search for a name for a lay language. I'm sure that all of us are professional here. So it makes the bones brittle. Okay, so it causes the formation of new bones in a woman's body when they are taking the depot, and that causes more chances of women developing osteoporosis. So the incidence is more before 20 years of age and after 40 years of age. So after 40, especially after the 50 years of age, if the woman is using depot contraception from 40 years till 50, then woman will not have adequate time to recover that bone formation, because they are going to become menopausal after 50 years of age. And then they put themselves at risk of developing osteoporosis, which is very, very bad for their bone health. So that is the recommendation. We gynecologists, we are not supposed to prescribe. These are the recommendation by colleges, that we are not supposed to recommend depot contraception at the extremes of reproductive age. IUDs, actually, the number of IUD insertion is rising, and I'm putting IUDs even in teenagers nowadays. They are doing quite well. So previously, I would say around 10 to 15 years, there was not much evidence before Marina became rampant in use. There used to be risk of having infection, uterine infection, and we used to worry about uterine infection causing infertility. But now there is a great evidence that Marina doesn't cause it, or even Kylina. So we are inserting Marina, Kylina to even teenagers. It's quite safe. So I hope I gave you the answer.
Thank you. Thank you.
Dr. Vaishali, there is a question in the chat. And the question is, hi, is tubal ligation reversible process if a woman changes her mind about pregnancy?
It is reversible, but it's not successful. Okay, so what happens? I'll tell you what happens. The tubes per se, it's not just a pipe. Okay, so inner lining of the tubes have got very delicate cells. Okay, and those cells have got small hair, and that hair helps the sperm from the uterus to go to the end of the tube, where the sperm go out and meet with the ovulation, the egg, and that's where the fertilization happens. That's where the embryo is formed, and then that embryo is picked up by the end of the tube, which we call at fimbria, and then that is slowly transmitted to the tubes by this hair of the inner lining cells of the tubes. So when we cut the tubes, that structure is injured. Okay, so and that is replaced by the scar. So even if we want to join back the tube, if we join back the tube, there will be a scar, and those hair are removed. Okay, so there is no function left for the tube. Like, they can't then move that sperm toward the tubal ostia, and from tubal ostia, they can't move the fertilized egg to the uterus. So then usually what happens is that somehow the woman don't get pregnant, or if they get pregnant, that egg, fertilized egg, usually gets stuck into the tube, and then they can have ectopic pregnancy, and that's dangerous for women's life. Okay, so the second thing is that the length of the tube also is important for women to get pregnant. That length gets shortened after we do the operation and try to reconnect it. So it's not helpful. So like 30 years ago, when I was a trainee, we used to do a lot of recanalization position. But now we have understood with a lot of evidence that IVF is better choice for these women having the pregnancy rather than tubal ligation. And it's expensive. It's not covered by Medicare. Rather, a couple can have vasectomy, and if they change their mind, they can have the recanalization procedure for that vas which has undergone cutting, and there are more chances that they can get pregnant.
Thank you, Dr. Vaishali. Kara, one of our participants, has her hand up. Is it for a question? Go for it, Kara.
Hi, how are you?
Good, thank you.
I work with young people with intellectual disability. So my question is, I'm just wondering about supporting the cohort of young people with the best way to support about and inform and collaborate when it comes to reproductive health for young women with an intellectual disability.
Yeah. So this is so important. You raise this issue. I work with one of the couple of actually Aboriginal organization in Northern Territory. I support them. So these people, I'm just going to give you one example because that, I think that is going to help you, and to reach out to me anytime. And
thank you.
to if you need my help. So what I was going to say is that these Aboriginal population, when I joined them a couple of years ago, I expected them to have a lot of unintentional pregnancies and high rate of termination because their women start getting sexually active from the age of 11. Okay, and many of them fall pregnant, like intentionally fall pregnant before 20 years of age. It's not uncommon for them to have a child and then finish having family by the age of 25, 30. So what they are using is that as soon as girls go into puberty or they start having their periods, they put the implanon in. Okay, so I have seen almost 99.99% women, girls who are having implanon. I have not come across, like whenever I talk to them or consult them, all of them have got implanon. So I would strongly recommend to consider implanon. And we can facilitate that at DPV Health. And happy to talk with the decision makers.
Because that's the other part of it.
Yeah, I know. Yeah, so because see, the women need to be ready physically, intellectually, psychologically to have another child, another responsibility.
Yes, of course.
And if they don't know this, then it's best to put the implanon as soon as they start having their periods. And of course, then to
and they start, the young ladies I work with, majority of them got their period when they were 9. So because the parents, speaking with the caregivers or their special people at home, that's the other part of it, isn't it? Because a lot of times the young women are wrapped in cotton wool from a very early age, and the assumption that they are not sexually active or is just crazy. But it's really tricky for some of the parents to to come to terms with or accept or thank you.
I feel you. I know where you're coming from. So as you were saying that the age of menarche means having the periods is going down considerably up to 8 years of age, because girls are having high BMI, and what is seen that as soon as they hit the weight of 30 kgs, most of them will start having the period. Okay,
Right.
so even if they are like 10 years old, like if you come and see me as a gynecologist, I'm going to okay Implanon. Okay, of course, that early age, usually GPs are not very comfortable saying okay to Implanon. They will be worried, and I understand what they're coming from, where they're coming from. But it's better that girls have Implanon rather than have pregnancy.
Yes.
And the second thing is that giving this population, like videos or some photographic, because their photographic memory and understanding is much better than general population about what sex is and what is harm, how to say no, and what are the dangers they can have, is really good, good way to promote things. And the third and the last thing is that testing them for STI every 3 monthly. Okay, we can just do a urine test.
Yes, all right.
Just do a urine test for chlamydia and gonorrhea, which is the most common STI in Australia.
Excellent. Yeah. All right. Thank you so much.
You're welcome.
Does anyone else have any more questions? All right. Thank you so much, Dr. Vaishali, for all of that useful information. And we really hope it was, valuable for everyone online with us today. If you are after any further information regarding our sexual and reproductive health hubs at DPV Health, or any more information about women's health or sexual and reproductive health, please visit the DPV Health website. The link is available here on this slide. We will share a copy of this presentation with all participants after the session. In order to make bookings for the sexual and reproductive health clinics, you can either call the 1300 number at DPV Health, which is 1300-234-263, and select option 1 for medical. Or you can book online via the Health Engine portal, which again is available on the DPV Health website under the medical section. More information about women's health topics and sexual and reproductive health are available at the links provided here within the slide, which again you will have available to you once you receive a copy of this presentation. This is our first session, and we have 2 more sessions planned as part of the series. Our next session is scheduled for Thursday, the 18th of September, and the topic for that session is endometriosis and pelvic pain. And the third session is on the 16th of October at the same time. And that session is on perimenopause and menopause. Now, these are all topics that we've found, we've heard from our existing clients are really relevant for our community and for women out there. And we really hope you'll be able to join us for these next sessions as well. Thank you so much for everyone who took the time out of your busy schedules to join us today. And we really hope once again that the session was useful for you in some way or the other. Please reach out to our medical team and to our women's health team via the website or the phone number for any kind of assistance or any support going forward. Just one more thing. Soon after this session, we may send through a survey link to all participants just to collect your feedback on today's session, but also on the topics that were covered today and to see how useful it was for you so that we can improve not just our sessions, but also our service planning and the way we deliver our services going forward. All right. Thank you once again, everyone, and enjoy the rest of your day.
Thank you very much, Pooja.
Thank you.
Thank you.